Size.
You are full screen.
Brilliant. So good morning, everyone. Thank you for joining. This is a talk about a project I am going to do. So I don't have any data to show you, but I'll show you some ideas. The project, as Catherine said, is called Brain AI. And just to make a nice name for initials, we have some very long words underneath. I'll start with a little introduction of myself. I am a physicist by training, and I work clinically at Southampton General Hospital. My formal title is medical physics expert, which is mostly expert of nothing, but what I need to sign my name against. My job is to lead the development of imaging services. So I help with applications in oncology, in cardiology, and neurology. Specific to dementia, which is the center of my project, I'm involved in doing quantitative analysis of brain scans, and I help our neurologists in interpreting the imaging results for those scans. The aim of my project is to improve the diagnosis of dementia. Now, just to tell you about this presentation, this is an expanded version of a presentation I will be giving next week to the NIHR Academy. I have put in a funding application for a clinical lectureship to support me to do a research project in the next 3 years. So for that reason, I will be presenting you my research ideas, but no results, sorry. Hopefully those will come in a few years' time. Just to start on the background and talk about dementia, this is a progressive disease and a degenerative disease. It affects our memory, our thinking, our ability to find words, and it impacts everyday quality of life. Now, in the UK, I was surprised to find that it is actually the leading cause of death. It has sadly, recently, exceeded deaths from heart disease, and the ballpark figure for death caused by dementia is about 70,000 per year. So it's similar to that of COVID in the last year. Now, for people born in 2020, 1 in 3 are expected to develop dementia in their lifetime. It affects a lot of people. Currently, in the UK, we have 850,000 people living with dementia, and this number is rising. Essentially, about half of us already know someone with dementia, and a third of us have a family member living with dementia. At this moment in time, 1 in 4 hospital beds are occupied by patients living with dementia. And cost is another consideration here. So the Alzheimer's Research UK did a calculation, and it appears that costs for dementia at the moment, well, actually a few years back, are at 26 billion. It's not just the financial cost, we also need to think about the human cost and the cost for supporting individuals with dementia. We talked about having 850,000 patients. We also have 700,000 informal carers who provide non-paid support to their family members. Now, looking at diagnostic strategies, when patients visit the clinic, when they have their first symptoms, they often have 2 main questions in mind. The first is, do I have dementia? And the second is, if I do have dementia, what does that mean for my future? How long have I got? Now, we use a lot of different tests to try and answer those questions. We use cognitive assessment questionnaires. Those are long lists of questions and evaluations of cognition and function, daily function. We also use scans of the brain. We do things like computed tomography, CT scans, we do MRI, and we also use functional scans, such as SPECT in nuclear medicine and PET. that can show us perfusion of the brain or metabolism or specific functions. In addition to the scans, we occasionally do tests of the cerebrospinal fluid, where we take a small sample of cerebrospinal fluid and analyze its contents for proteins that relate to dementia. Now, all those tests are very good at detecting advanced stages of the disease, and some of them are doing okay in early stages, but what they fail to do is determine which patients with mild symptoms are likely to progress and develop dementia, and which ones are going to just stay with mild symptoms. And it appears that about a third of patients with mild symptoms progress to develop dementia. So we are missing this ability to tell who is going to progress at the moment. For that reason, dementia diagnosis remains complex and it is subjective. Currently, it takes over 2 years on average from the time a patient visits the clinic with their first symptoms to the point we can provide a diagnosis. And that tells us we need better tools to be able to predict the progression of the disease. Now, oops, my slides are not moving. There we go. Sorry about that. There is new evidence that might help us with this prediction. In the last 10-15 years, people working in immunology have been trying to understand the role of inflammation in dementia. What they are looking at is infections and peripheral inflammation that those infections cause in our bodies and how those interact with our brain. It appears that the blood-brain barrier, which separates our brain from our body, is actually degrading with time and with disease. It becomes leaky and it lets peripheral inflammation affect the brain and accelerate neuroinflammation. Looking at some data, and this is a study from Southampton, from Professor Clive Holmes, where they looked at patients with mild cognitive impairment and took blood samples from those patients to measure and evaluate inflammation on those samples. And they followed up those patients over 6 months. And every 2 months, they were doing another cognitive assessment to see how their cognitive performance is changing with time. What this study showed is that for patients without inflammation, there was a generally stable cognitive performance, while in patients with systemic inflammation, there was accelerated decline of cognitive performance. And the conclusion of their study was that systemic inflammation accelerates dementia. Now, there has been a lot of other studies verifying these results and also looking at specific causes of inflammation, such as heart disease, diabetes, gum disease, and arthritis. In my study, my hypothesis is that I can use markers of inflammation together with some of our established diagnostic tools, such as brain imaging, to improve the diagnosis of dementia. To do that, I will work with the immunology group at Southampton, and we will measure markers of inflammation in samples we have already collected from a previous study. You might have heard about the brain imaging in dementia study before. It's a study run by Dr. Chris Kipps, and the main researcher in that is Angus Prosser, who I believe has spoken in this panel before. In that study, we are observing patients' diagnosis from baseline and all the way to 2 years follow-up. This study is collecting imaging data from these patients and also other records that come as part of the normal hospital care, which include blood tests, and cerebrospinal fluid tests. Now we're going to use this data to measure markers of inflammation and try to find out if we can predict at the baseline point where patients have few signs of dementia, which patients are likely to progress to show us advanced disease, like this instance here, based on inflammation, and which ones are likely to be stable. Now, to bring these inflammation markers into clinical practice, I'm going to design a diagnosis support tool. This is a computer algorithm that will use artificial intelligence. Artificial intelligence helps us combine multiple different measures in one setting. And that explores the most information available to provide a more accurate outcome. Here, my artificial intelligence algorithm will combine the inflammation markers with the brain scan results and also the prior information we have from our patients, their demographics, clinical history, and cognitive tests. Putting all those together, we will try to calculate a likelihood of dementia and also a likelihood of this dementia progressing in the coming year. I want to develop this tool with input from our public and patients in order to feed it with the right information and also to try and answer the right questions. I will also develop it with the support of neurologists so that it makes clinical sense. And I will validate it using the clinical data from the BRAID study so that we can enable rapid translation. We are hoping to revolutionize dementia diagnosis, and importantly, we want to be able to better answer our patients' questions on whether their disease is likely to progress. Now, in laying the groundwork for this study, I am currently working, as of today, this is my first day working on a SHAPE award, which was provided by NIHR Wessex. And this is giving me a day a week to look at preliminary analysis of the collected data and samples to start my research. I was also awarded the TOPL Fellowship, which is starting next month. And this is an opportunity to focus on artificial intelligence. So it is an opportunity to work with experts from NHS Digital to develop the artificial intelligence solution, the diagnosis support tool. Going forward, I have applied for a clinical lectureship with NIHR, and if I'm successful, this will start next year. And that would give me the opportunity to link the two groups in our hospital, link imaging with the neuroimmunology team, and expand my collaborations beyond UHS so that we can see if the tool we develop can be applied at other hospitals. I'm hoping to grow public engagement networks to drive this research. Because it's a lectureship, I need to develop myself. So I am hoping to become a clinical academic leader and to register as a consultant clinical scientist, which is a portfolio-based registration in the UK. And of course, I will be looking for further funding to try and translate the diagnosis support tool, the innovative technology, to other NHS sites. Now, before this meeting, you have seen an email from Mike and Catherine with a dementia survey. And I'd like to thank you very much for participating. As of this morning, we had already 16 responses to the survey. And I personally find the results very interesting and very useful in how to move my research forward. So starting with the first question on whether patients and public feel comfortable to use computers to interpret their scans. There were no negative responses, and it was a very clear majority that we are happy for computers to help with the scans, but it is the doctor who should make the final decision. And this is something that aligns with the development of my project, which is looking for a diagnostic support tool, not an automatic diagnosis tool, nothing to replace the doctor, but something to help the doctor with some quantitative data to help them make a better decision. Then in terms of additional tests, and there will be more questions over that actually, looking into inflammation and whether we feel happy to take additional examinations to help us look into inflammation. The majority of people say yes, and there are also answers of being unsure, which is completely understandable, because if we don't understand what the benefit is, we don't know if we want to take these tests. And it would be down to our neurologist to explain the benefit when prescribing those tests. Now, most of the inflammation would be measured through blood tests, which are easy. I do have another question for you, and I will ask for an answer at the end of the presentation, which is, would you feel comfortable having painful tests, such as a lumbar puncture, for example, in order to try and measure inflammation, a measure that might or might not help? Because we are still in a research setting, we don't know for sure that it will be helpful. So I'll get back to that question in a minute, but let's look at priorities as well. So I asked, in your opinion, what is the most important aspect of dementia diagnosis? And the overwhelming majority said the certainty of diagnosis, while a few responders said the length of time it takes is important, and that's understandable because we know it takes a long time for diagnosis. Very interestingly, about 19% of responders said none of the above. It's not the length of time, it's not the certainty, it's not the number of tests required. So it would be very interesting to know what is actually the most important aspect, to see if I can address that in my research. Now, NIHR have also asked me to talk about the impact of COVID-19 on my lectureship, and they're mostly interested in whether it's going to affect the timeline of this project. Now, I am going to be working on a retrospective analysis of data. These data have already been collected as part of BRAID, so we have the samples, the scans, and the cognitive assessment questionnaires. And for that reason, we expect the COVID-19 impact to be limited in terms of data collection. We would have some limitations with regards to visiting the labs and performing the inflammation markers analysis, but we have worked out a rotation system with infection control measures to do this work. It would take a bit longer, but it is feasible. And finally, the patient and public involvement program is typically an in-person interview, but for the purposes of this project, and in order to be able to have input from patients and the public into my study during the pandemic restrictions, we are going to instead use online surveys and virtual meetings like this one today and more to follow. And hopefully at the end of the project, if restrictions have been lifted and if we've all been fortunate enough to have the vaccine, we would resume in-person meetings. So that's all I have. Thank you very much for your attention. Any questions?